Today's session we're going to be looking at a practical procedure of umbilical line insertion. So in a moment our facilitator Mark is going to show the video demonstration of this, but beforehand there's just a little bit of theory that I would like to run through. So just for those of you who are perhaps unfamiliar with the concept of using the umbilical vessels for vascular access, that's simply all it is. It's a procedure that is unique to neonatal care. It's only something that can be undertaken when a baby is newborn, when the umbilical vessels are patent, and it's an easy way to establish central venous access or arterial access if needed. So why might we want to undertake this procedure? Well, there are a few indications. For an umbilical artery, you may want to get access if the baby is ventilated, and this will allow you to take regular blood samples for a blood gas analysis, which is important to be able to titrate the ventilation settings accurately. You can obviously use a capillary sample, but given how frequently the samples need to be taken, it won't be long before the heels become very traumatized from repeated lacerations with the lancet. The other advantage is that it allows for a continuous, accurate blood pressure monitoring. And so usually if a baby is unwell enough or preterm enough to require ventilation, then there's a risk that they may require inotropes as well. And so you want to be able to monitor the blood pressure accurately. And the other indication is for an exchange transfusion. So the only indication for that would be if a baby's got a very high bilirubin level that's reached the exchange level threshold, and an arterial line will be needed to help with that procedure. There are some contraindications as well, though. If the cord is infected, there's umbilical sepsis, then it's not right to put in plastic where that can harbour more bacteria and cause more problems. The other similar infectious concern is necrotizing enterocolitis, or NEC. That's a gut inflammatory condition that neonates can develop, and so you don't want to be putting lines in disrupting the perfusion to the gut with umbilical lines. If there's a congenital abnormality of the umbilicus, then you may not be able to access the lines or the vessels, or it may be unwise to risk causing any trauma if later some surgical repair is needed. And finally, if there is a vascular compromise to the lower half of the baby, then you don't want to make that worse by impairing the blood supply to the legs or buttocks by putting an UAC in. So that's an arterial umbilical line. There are a few more indications for an umbilical venous line. So in our network guidelines, when a baby is an extremely low birth weight of less than 1 kilo, then they always need to have an umbilical venous line. And that's usually going to be because they're very preterm and because they will need infusions that require central line access, typically TPN. If the baby is ventilated, again, it's likely because they're so preterm and they're going to probably need central line access for infusions, or similarly if they're very sick. And I've also listed the need for central line access as an indication in its own right. So for example, if we've got a baby that requires a high concentration of glucose because they keep dropping their sugars, then that might be a suitable access route. And again, similarly with the UAC, an exchange transfusion is another reason to put an umbilical venous line in. And the contraindications are virtually the same, with the exception that poor perfusion to the lower limbs shouldn't be a reason not to put in an umbilical venous line because it won't affect the perfusion. Okay, so we'll cut to the video now.
Welcome to this practical demonstration on umbilical line insertion. Before gathering and setting out your equipment, there are a few things that you need to do first. To begin with, identify an assistant. Once you are scrubbed and sterile, you won't be able to abandon your sterile field, so it's important that you have an extra pair of hands in case you need anything else. Secondly, make sure that you've prescribed the fluids. We use these fluid prescription charts. Either do this yourself or delegate the task to somebody else so that the nursing staff can prepare the infusions and have them ready to connect as soon as the lines are secured. Then you want to make sure that you've got enough space around the area, around the baby therm or the resuscitaire. The nurse looking after the baby can help assist with this, and it's important that they're aware the procedure is about to take place. Then you want to calculate how far you're going to be inserting the umbilical lines, and there are a few techniques that can help with this. There's a Neomate app that can calculate the lengths and also the size of the lines based on the baby's weight or gestation, or there are formulae available on the network guidelines. In an emergency for the UVC, you can directly measure the distance between the umbilical cord and the xiphisternum, which is about 5 centimetres in a term baby. Don't forget, whichever method you use, you want to make sure you add on the length of the remaining cord stump. Then you want to make sure that you've given your bleep to somebody else so that you're not interrupted during the procedure. And finally, if you're able to, discuss the procedure with the parents to give them an opportunity to ask any questions and be aware of any risks such as thrombosis and sepsis.
To start with, I'll run through the equipment needed for this procedure. So first of all, you'll need a large metal procedure trolley, and then your umbilical catheter pack. This contains drapes, gauze, all the instruments you'll need such as forceps, scissors, dilator and a scalpel, gallipots, syringes and a tape measure. You also need some sutures for securing the lines afterwards, and your cleaning solution including chlorhexidine. And remember, with a preterm baby, you also need some sterile water to help clean the solution off so it doesn't burn the baby's skin. You also need the umbilical lines themselves. So the UVC, you'll note that this is a double lumen and it only comes in one size. The UAC is a single lumen and this comes in different sizes. So you want to use a 3.5 French for a very small preterm baby. And it also comes in larger sizes such as a 4 French and a 5 French for a bigger baby. And the way you know which one you've got is it says at the back. So this one is a 3.5 French for a small preterm baby. You also need some bungs and some 3-way taps, some saline and some filtering needles to flush your lines, some elastoplast tape for securing your lines at the end, and obviously you'll need your sterile apron and sterile gloves. So now I've got all of the equipment ready on the sterile field. I've got my sterile gown on and I've double gloved with 2 lots of sterile gloves. So now it's time to prime both of the lines with normal saline. So got our filter needle and our syringe, and with the help of my assistant with 0.9% normal saline, we'll draw this up. Ensuring that we get rid of the bubbles. Attach it to the end of your UAC. Flush the line. Remember to turn the bung off to the baby, and there's prepared. We'll do the same with the UVC. So again, we're drawing up the saline, getting rid of the air. You need to flush both of the lines, clamping off as you go. And the line that you're not using with the syringe, then you obviously need to put bung on that. So now we've got our baby on the sterile drape on continuous monitoring. It's time to clean the cord and the baby. So with my chlorhexidine soaked gauze, I'm going to get the cord clamp, cleaning that as I go. And then with a second chlorhexidine soaked gauze, I'm going to clean the remainder of the cord and the surrounding skin of the baby. With a preterm baby, remember, you also need to have some water, sterile water soaked on the gauze to clean off that chlorhexidine solution from the skin. Now we can put our sterile drape with a hole cut in it, and your assistant will be able to help you with that. We now have our sterile field, and I can take off my outer layer of gloves. For an additional area to have all your equipment, you can always apply a second sterile drape just to give you a slightly bigger sterile field. So now you're going to attach your cord tie at the base of the cord, and it's important to do this because if there's any oozing from the vessels when the lines are inserted, then you can quickly tie this to prevent any excessive blood loss. We're now going to cut the cord, and you tend to want to do this about 2 centimetres from the skin. So first of all, clamp, and then with a single motion away from yourself, you want to cut the cord with one seamless motion. You don't want to be sawing, as that can damage the vessel walls and make it harder to insert the lines. So once you've cut, if there's any oozing, you can just dab. So now you're going to identify your vessels. So there should be 2 arteries which are smaller and have more muscular walls, so tend to stand proud of the cut cord. And then there's a larger vein which has thinner walls and so tends to gape.
So on this diagram here, which was taken from the Newborn Life Support Manual, this shows quite a good 3D image of what we've seen here on the video. You've got the umbilical cord that's been cut very close to the abdomen, and what you can see is the vein usually is quite collapsed down and a bit bigger than the arteries, which stand proud, and the vein is situated more towards the head end, and the arteries are towards the feet, so they're oriented that way round, which I think shows a bit better on this picture than in the model on the video. So we'll go back to the video now.
When it comes to inserting the umbilical lines, there's a couple of techniques that you can employ. You'll notice that the umbilical cord can be quite slippery and difficult to stabilise. So one technique is to use a piece of sterile gauze and wrap it around the cord, enabling you to hold it securely. Alternatively, you can use forceps to clamp the edge of the wall of the cord and stabilise it that way, or a combination of the two.
So now it's time to insert our lines, and I'm going to start by inserting the UVC. So I've located my vein, and I'm just going to very gently dilate the opening. It's important that this isn't inserted too far or with force, as you don't want to create a false passage. Then with my primed catheter, I'm going to gently insert it to the desired length. And there's numbers on the side to assist with this. Once I'm happy it's in the correct length, then I'm going to aspirate, and if it's in the correct place, you'll see that blood easily comes up the line. So once I've flushed the UVC with normal saline, I'm going to go on to insert my UAC. So it's a very similar technique. You locate your artery, gently dilate with the dilator, and then with your primed UAC, I'm going to insert that in the vessels. And you may find it easier to do this with some forceps to get a little bit more control. And again, we're going to insert that to the desired length using the numbers on the side of the catheter. And again, once you're in your desired length, simply pull back on the syringe and you'll aspirate blood.
That you've put the catheter in a vein or an artery, one thing that you can do is aspirate a little bit of blood so that you can see it in the catheter, then pause and watch to see if it pulsates. If it pulsates, then you know you're in an artery, because a vein will never do that.
Once you're happy with the position of your umbilical lines, you may wish to take a sample of blood. It's very important to take a good discard before then aspirating the blood for the sample itself. After that, you'll need to make sure it's flushed through with saline before moving on to securing the catheters with sutures, which I'm going to demonstrate now. When it comes to suturing the catheters in place, you want to be holding your needle with one pair of forceps, and then you need another pair of forceps to then grab the needle as you've pushed it through the cord. It's extremely important to not pierce the catheter itself. Take a good chunk of cord. And pull through all the way, but make sure you leave a good length to knot the suture, and then it will need to be sandwiched in between elastoplast to secure it. And then I'm going to cut it with scissors. And it's easiest to tie it with your hands. So I do at least 2, if not 3 knots to make sure it's really secure. Okay. You then will need to do exactly the same on the other side of the catheter. And once you've done that, for additional security, you can tie around the catheter itself. If you have a UAC and a UVC in situ, you will need 2 ties for each catheter, so in total you would have 4 sutures.
So once you've inserted your 4 knotted sutures, 2 for each catheter, you then want to secure it with a piece of elastoplast. So with this, I find it's easier if you turn over the corners just so it doesn't stick to your gloves. Then you want to place the sticky tape underneath with the help of your assistant. Ensure that the lines are all kind of held taut, and then you want to fold it over close to the cord, and then you want to bend your catheter line down and then fold again to secure it like so. Once the catheters are secured, you want to make sure that you add the arterial sticker to the arterial line so that there's no confusion between the 2 different catheters. Then you want to connect them to their infusions. To check the position of the lines, you need to order a chest and abdominal X-ray.
From the newborn life support manual shows that method of securing the lines a bit closer up in here. So hopefully you can appreciate how the sutures either side are what anchors the catheter in place, because it's all secured within elastoplast like that. So if there's any traction on the catheter, it pulls on those sutures and keeps the cord in place, or the catheter in place. And the other advantage of securing it this way is that if you need to adjust the line, you don't need to untie it from the catheter itself. It's much easier to do that. Okay, so after the procedure, a few things that are needed. It's mandatory to take x-rays to confirm the position of the catheters, and you must document that the procedure has taken place, and also the location of the catheters, both at the measured length of where they insert into the cord, and also the position on the x-ray, and we'll look at some x-rays in a moment. If the line does need to be adjusted, it must be done aseptically, but they must never be further advanced into the baby once the procedure is completed, because the line is no longer sterile. You can only ever adjust by pulling back on the line. If you the x-ray shows that the line is not in a suitable position and pulling it back won't improve that, then the only other option you've got is scrubbing up and starting all over again, removing the line and putting a fresh one in. If there are any adjustments made, then the x-ray must be repeated, and of course update the parents and let them know this procedure has taken place. So let's consider now what positions of a UAC and a UVC are suitable. This table, you'll find it in the network guidelines. It's quite a busy table, shows lots of different positions, but the main thing to remember is that the optimal position, and you've got a little bit more leeway with a UAC than you have a UVC, but ideally T8 to T9 for a UVC, or T6 to T10 for a UA. And as a rule of thumb, just remember that if you've got a line that's between T8 and T9 for either, then that's fine. Okay, so let's look at some x-rays now. Let's consider a UVC position to begin with. So we've got here an x-ray of a baby that has actually both a UAC and a UVC. And the way, it's really important that an x-ray combines both the abdomen and the chest, so that you can see the base of the lines where they, so you can distinguish between an artery and a vein. So the UVC will always go straight up, whereas an arterial line bends down first into the iliac vessels before then coming up into the aorta. And that's how you can identify which is which. Then how do you determine which vertebral level the catheters are lying at? So the best way to do it is count from the lowest rib and also from the uppermost rib. So it looks here on this x-ray like this is probably rib number 12, which would make this vertebral level T12. So we count up 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. And T1 should correlate with where the first rib comes off. And if that's correct, you can count down 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. And if that all matches up, then you can be fairly sure where T12 is. And then you can then identify where your catheter tip is lying in relation to that. So 12, 11, 10, 9. So it looks like the UVC tip is at T9, and according to our table here, that's perfectly fine position. Okay, this x-ray shows what we don't want, and that's where the UVC diverts into one of the hepatic vessels, and that's not an acceptable position for a UVC, so that would either need to be pulled back or removed and resited. Let's look at another x-ray and consider the UAC position. So here you can see quite nicely how this catheter, it migrates down before coming back up again, and as we said already, that tells us it's an artery, and this here is the UVC, and you can see quite easily where the tip of the arterial catheter lies. Again, we can employ our technique for counting where the tip lies. So if this is T12, 12, 11, 10, 9, it's lying between T8 and 9. Okay, so a few things to consider when a baby has umbilical lines in. it's important to remove them as soon as they are no longer needed, because there are risks with having plastic inside a baby, including sepsis, infection of the cord itself, central lines. There's a risk of a clot forming within it and thrombosis formation. And if it gets dislodged, then you can have problems like a stroke or renal vessel thrombosis. Air embolism, similarly, and if the line gets dislodged, then it can bleed quite significantly, and I don't think that should ever be taken lightly. I have known of a case where a baby had an umbilical artery line fall out, and it was about 15 minutes before it was noticed, and the baby lost about 2/3 of its blood volume and needed an emergency transfusion. So it is quite a serious risk that needs to be watched for. So for that reason, babies who have umbilical lines in should always be nursed in the supine position, with the nappy not covering the cord, so that the site is always visible to the nursing staff. They should never be placed prone or covered. When it comes to removing the lines, then it's really important to make sure that a cord tie is in situ, in case when removing the line there is excessive bleeding, and that's more likely to occur with an arterial catheter. The infusions should be switched off for at least 30 minutes prior, and again that's especially important if you've got a heparinized UAC infusion running. The cord should be cleaned before removing the lines, and they should be removed slowly. Again, especially important if it's a UAC, do it over 2 to 3 minutes to enable a time for the muscles within the artery to constrict and for there to be clot formation as the line gets removed. Then look at the tip, make sure it's intact, and then afterwards the baby needs to be nursed supine again for a further few hours, just to make sure that there is no bleeding. Okay, well that's the end of my presentation. If anybody has any questions, I'm happy to take them.
How old can the baby be, or what's the oldest they can be to insert the catheter, or is it just when you can see vessels?
So the younger the baby is, the more newborn it is, the easier it will be, because those vessels will still be patent. In theory, up to a few days old, but it depends. If you want to put an umbilical vessel in the baby that was 48 hours old, and you actually got to the baby and stuff, it might be that it's already peeled off and you can't do that. So ideally it's something you want to do in the first 24 hours of life, but in theory you can do it up until they're a few days old. But most of the time, if you're going to need to put an umbilical line in, it's something that you're going to, it's going to be required in the first 24 hours of life. It's unusual to have to do that later down the line. Does that make sense, Aisha? Yeah, okay. Anybody else have any other questions? No? Okay, well, thank you for listening, and we'll leave it there.